Hello everyone. Very good evening to all of you. Am I audible and visible to everyone? Just a quick thumbs up. Am I audible and visible to everyone? Namaste Ayush, namaste Anos. Good evening to everyone. Good evening. I think I am audible and visible to all of you. So let's start. So it's a high yielding topic series which I have started. And through this series, what I want to do, I want to let you know that these are the important topics which had been asked in earlier exams in the last 5 year or last 10 year of the exams like INICT or FMG or NEET PG exam. So this will be helpful for all kind of students, those who are preparing for NEET PG or INICT or for FMG exam. And these topics are very crisp. It will be very short session of 15 to 20 minutes. But please try to notice how I am framing the question, how language is going to get changed, how to tackle the MCQ, what is the trick behind that. All these things you have to observe apart from the seeing which topic is important, because these topic you must revise from your notes in a exhaustive manner, right? So whatever notes you are having from my side, or who are using my app or you have attended my lecture, to try to read these topics completely from your notes, and you will definitely get very good insight, and in your exam you are not going to commit any mistake. So let's start. This is for FMG also, this is for NEET also, everyone. So this is a kind of a series which I have started. This is the first episode where I will be discussing high yielding topics only. Anurag, did you understand? Yeah. Right. So I will be putting question. I will be giving you half a minute of say 30 seconds to give me the answer. So let's start. Question number one: which of the following will be activating MLKL mixed lineage kinase domain like pseudokinase during programmed cell death? Tell me what should be the answer for this question. And I will tell you, this is the question. This is the question from the Robbins 10th edition. This is the update of Robbins 10th edition. And you may find this question in your exam. Tell me, what should be the answer? So, first correct answer, I will announce. Just let me see how many of you are attempting. Try to attempt, don't worry. First correct answer was given by Anu ST, right? So please remember, what is this question? This question is about MLKL. So please remember this MLKML, as I said, it's a new thing which has been added in the new Robbins, right? MLKL is a mixed lineage kinase domain like pseudokinase. It's a compound, right? It's a compound, and what they will do, they will form the oligomers which will deposit into the cell membrane, and after that cell membrane will be getting rupture, and because of rupture they will have inflammation, right? So this is a kind of a programmed cell death. This is a kind of programmed cell death, and this programmed cell death is necroptosis. So if I ask you to whom they belongs to, so we can say that this belongs to necroptosis, right? So this is for necroptosis, where you will see this, right? MLKL. So in necroptosis, caspase 1 and caspase 11, where you will see them in comment box. Can you tell me caspase 1 and 11 in which process? Necroptosis or pyroptosis? So this will be seen in pyroptosis, right? So this will be seen in pyroptosis. That is the one important thing which we have to remember. So it is not seen in necroptosis. So option A and B is ruled out. If you know all these things, if you have gone through my notes, you can easily rule out these things, right? Caspase 1 and 11 is with pyroptosis, right? So simply I will say that if I say that programmed cell death, if I say that programmed cell death, it can be of two types, right? It can be of two main types with context with the question I'm talking about, right? Either they will be using caspase or no caspase. So when they are having no caspase, that will be called as necroptosis, right? That will be called as necroptosis. But when they will utilize caspase, then it can be pyroptosis, and it can be apoptosis also, right? So how you will differentiate? Pyroptosis will be involving caspase 1, 4, 5, and 11. So again, remember, this is again update of the new Robins, right, where they have added 4 and 5. Initially it was 1 and 11 only, right? So that's the point you have to keep in mind. But when you will see programmed cell death with caspase, when you will say it is apoptosis, when they will involve caspase 3, 6, 7, 8, 9 or 10, right? So all these are associated with apoptosis, right? So that is the point you have to remember. So again, I will repeat, programmed cell death, whenever somebody is saying programmed cell death, either there is two possibility: either they will be having no caspase involvement. When there is no caspase, necroptosis. When there is a caspase, it is apoptosis or pyroptosis. So who will discriminate them? It is the nature of caspase. If nature of caspase is 3, 6, 7, 8, 9, 10, it will be a apoptosis. If it is a 1, 4, 5 and 11, it will be the pyroptosis, right? So now these two things are ruled out. Again, I will tell you, when necroptosis is going on, RIP1 and RIP3 both will be involved, right? But remember, RIP1 will come earlier, RIP3 will come later on, and this RIP3 will activate the MLKL. So our right answer should be D, right? So correct answer will be D for this question. So that is what you need to remember, right? So this is what we need to remember for our exam. So now I will just discuss you a brief outline of the necroptosis. See, necroptosis, as I said, what is this? It is a programmed cell death without caspase activation. So please remember, it is without caspase activation. So please remember, it's a programmed cell death without caspase activation. So what happens here? Tumor necrosis factor, right? What are you seeing here? This is a cell, right? This is a cell, and now you are seeing this is the membrane of the cell. So on the membrane of the cell, there is a death receptor called as TNFR, right? So tumor necrosis factor will combine with tumor necrosis factor receptor. Understand? So on the membrane, what we are seeing, tumor necrosis factor receptor, which will combine with their complementary ligand, which is called as tumor necrosis factor. So receptor and factor, when they will combine, what will happen? They will go inside the cytoplasm and they will activate RIPK1. Right, RIPK1 is a receptor interacting protein kinase. Please remember, RIPK is receptor interacting protein kinase. So RIPK1 will come first. See, number 1 will come first and then number 3 will come. It's a simple alphabet, right? Simple thing, right? Simple numerics 1, then after that 3 will come. So first RIPK1 will come, then it will invite RIPK3, and this RIPK3 is going to cause MLKL phosphorylation. So now you understood, this was our question, right? Who will do the MLKL phosphorylation? So RIPK3 will do the MLKL for phosphorylation. Because of this, what will happen? Oligomers will be formed. As I said, there will be a cell membrane damage and inflammation. So now I want to ask you a question, right? Please tell me in the comment box. If I say it is a programmed cell death without caspase activation, and there is a cell membrane damage and inflammation, so can you tell me what is necroptosis? It's a variant of apoptosis or variant of necrosis? Can you tell me what is necroptosis? It's a variant of, tell me, what should I write now? In the comment box, I want to see necrosis or apoptosis. Very good. Anurag, Kunj, Manish Reddy. Very good. So all of you are going correct. So whenever cell membrane is damaged and there is a presence of inflammation, that will be variant of necrosis, right? So what we will say that this is a variant of necrosis, right? So this will be variant of necrosis. So now you understand how examiner can ask other question. First, MLKL belongs to necroptosis, right? Number 1, right? What are the other things in the necroptosis? TNF receptor, RIPK1, RIPK3, MLKL phosphorylation, then oligomers, cell membrane damage and inflammation. Because of membrane damage and inflammation, we will say that it's a variant of necrosis, right? It's not both. It's not apoptosis. Please remember, in apoptosis, cell membrane will be intact and there will be no inflammation. Cell membrane will be intact and there will be no inflammation. But in case of necrosis or necroptosis or in any other condition where cell membrane is getting damaged, there is inflammation, they will be considered as variant of necrosis, right? Very good, right? So just have a look of the pyroptosis. Pyroptosis is another programmed cell death. As I have told you, it's another programmed cell death with caspase involvement. Which caspase? 1, 4, 5 and 11. So these are the caspases which are involved in the pyroptosis, right? So here again you can see I have shown you a cell membrane here which is belonging to this cell, right? What is happening here? You can see there are two receptors. One is on the surface which is called as toll-like receptor, right? Second receptor is in the cytoplasm. So I am showing you two receptors, one on the surface of the cell, one inside the cytoplasm, and the antigen is coming, right? So this antigen, either they will come to the surface via toll-like receptor, or they will come into the cytoplasm and they will be taken up by nod-like receptor. So there are two receptors I am showing you right now. Understood? One on the membrane, toll-like receptor, one in the cytoplasm, nod-like receptor. Antigen can combine with both of them. So there are two mechanisms. It can come to the membrane also, and it can come directly to the cytoplasm also. So whatever, if they are coming through the membrane via toll-like receptor, they will do activation of pro-caspase 11 to the active form of caspase 11, right? So now active form of caspase 11 has been formed by toll-like receptors, right? Now this antigen, when they will come to the cytoplasm and nod-like receptors are involved, so what they will do, they will activate inflammasomes, right? What inflammasome will do? Inflammasome, what inflammasome will do? This was the question. They will activate caspase pro form. Pro means inactive form. So which pro form? Caspase 1, 4, 5. Remember, because in earlier Robbins it was only C1. So now it is the latest change. Pro caspase 1, 4 and 5. So pro caspase 1, 4, 5 will be activated to form caspase, active form of caspase 1, 4, 5. So what is the function of these caspase? So please remember, this was the question in a NEET PG exam. Caspase 1 will activate which cytokine? So answer is interleukin 1. So now you understand why this caspase activation is required. This caspase activation is required so that they can activate the inactive form of interleukin 1. So once they became active form of interleukin 1, what they will do? They will cause cell membrane damage and inflammation. So now you can see that here also we are seeing cell membrane damage and inflammation, because IL-1 is an inflammatory cytokine. They will cause inflammation. And what is the cause of inflammation? Cause of inflammation will be cell membrane damage leading to the leak of the intracellular content, and they will invite all the inflammatory cells. So that is why I always say that whenever there is a cell membrane damage, there will be an inflammation, right? Whenever there is a cell membrane damage, there will be inflammation, and here it is done by interleukin 1. So examiner will ask you, who will activate interleukin 1? So now you should remember there are three caspases, C1, C4, C5, and remember C11 will also do the same function, because if you see correctly, so what is the function of C11? C11 will also do the same function. They will activate this caspase. So pro-caspase activation is again done by C11. So this activated C11 is going to activate interleukin 1 and again causing the cell membrane damage and inflammation. So what we will say that pyroptosis is also a variant of apoptosis or variant of necrosis. Now understood? So it is also a variant of necrosis, right? So it is also a variant of necrosis. So now you understood this point. So please remember two important things I said. MLKL is the new point which is associated with necroptosis, and caspase 1, 4, 5 and 11 is associated with pyroptosis, right? So these are the important things for these questions. These updates you keep in your mind. Examiner may ask some question from here. Now come to the next question. This is again a very important topic where you can see this question in every exam, FMG, INICT, every exam you will find this question. Histopathology of Hodgkin's lymphoma. So you now understood what I want to say, that this topic of Hodgkin's lymphoma is very important, right? So try to revise this topic before you go to exam. You will definitely get one question, right? So histopathology of Hodgkin's lymphoma patient is shown below. Which of the following is correct statement? Now you tell me, which is correct statement? I want to see who is giving me the first correct answer. Okay, everyone is telling B. Can you tell me the diagnosis? Oh, who is this? Antima Sharma. Very nice. Antima has given me the first correct answer. Very good. That's great. See, this is a very, very good question. Why and this is, this is an easy question. I am telling you, this is an easy question because this is Hodgkin's lymphoma. You know that. Now you have to identify which Reed-Sternberg cell it is, right? So only one answer I am getting correct is Antima Sharma. That's all. Nobody has given me correct answer till now. Answer is C. Please remember, answer is C. Now, can you tell me what is the Reed-Sternberg cell here which you are seeing? Can you tell me? I'm just marking this is the Reed-Sternberg cell. I hope everybody is appreciating. So, can you tell me how is this Reed-Sternberg cell? How is the nucleus? It's not CMV. Where is the CMV? It's not CMV. No, no, no. Very good. It's a lymphocyte predominant. Very good, Abhijit. You got it. You got it. It is a lymphocyte predominant, and you can see the nucleus is having multiple lobes. So this will be called as which cell? Which Reed-Sternberg cell? Popcorn Reed-Sternberg cell. You have to catch popcorn Reed-Sternberg cell, and popcorn Reed-Sternberg cells are seen in lymphocyte predominant, right? That, like Abhijit has said. So if it is a nodular lymphocytic predominant Hodgkin's lymphoma, right? So now your diagnosis is nodular lymphocytic predominant Hodgkin's lymphoma, or simply we can also say that lymphocyte predominant Hodgkin's lymphoma. So our diagnosis is nodular lymphocytic predominant Hodgkin's lymphoma, right? So now you tell me, I will show you. First I will explain you, then I will come back to the options, right? So because it is a thing which you did not say, how to identify Reed-Sternberg cell when you have to see the popcorn Reed-Sternberg cell. See, classical you can identify, this is non-classical, right? To identify popcorn Reed-Sternberg cell, please remember, because we all know that popcorn Reed-Sternberg cell, and NEET PG exam I have seen once, they had asked question in 2019, what is the name of Reed-Sternberg cell in the lymphocyte predominant Hodgkin's lymphoma? So right now I am talking about nodular lymphocytic, right, predominant Hodgkin's lymphoma, right? So in short, I will be writing NLPHL. So nodular lymphocytic predominant Hodgkin's lymphoma, what is the name of Reed-Sternberg cell? LH variant means lymphocyte histiocyte rich variant of Reed-Sternberg cell. That is the name, right? So that is the name. So how you will identify, the nickname is popcorn. See, its nickname is popcorn Reed-Sternberg cell. So how you will identify popcorn Reed-Sternberg cell? You can see what I'm showing you. Nucleus will be either like a polypoidal lobe. So either polypoidal nuclear lobe will be there, or they will be multi-lobated in appearance, like this, right? So now you can see that in this Reed-Sternberg cell, when you are going to see the nucleus will be either polypoidal, right? So either polypoidal, or this will be looking like a multi-lobated. Now understand, so either polypoidal or multilobated nuclei will be there. So that is what you need to remember. So in this cell, if you look at this cell, please look at this cell. When you are looking at this cell, I will just make it more larger for you so that you can appreciate it, right? If you look at this cell, right, now you see in this cell, how is the nucleus? How is the nucleus in this cell? Can you see and can you appreciate the nuclei? If I show you the nucleus, you can see it is looking like a one lobe, second lobe, third lobe, fourth lobe, fifth lobe. Exactly. If you look at this cell, this is the continuous total cell, right? Now I think you can appreciate this cell, exactly multilobated nuclei are there. So that is why I said, if you are able to identify this multilobated nuclei, that means it is a popcorn Reed-Sternberg cell. So that is a hint. So these are the two things you must remember for your exam. Whenever you are going to appear for your exam, you should remember that either you should find this one, Just a minute. Either you should find polypoidal nuclear lobe or multilobated nuclei. So any of these things are present in the nucleus and examiner is saying that it is a Hodgkin's lymphoma. That means it is a popcorn Reed-Sternberg cells, right? So now understand. So popcorn Reed-Sternberg cells will be seen in nodular lymphocytic predominant Hodgkin's lymphoma, right? So nodular lymphocytic predominant Hodgkin's lymphoma, as I said, in short, we'll be writing NLPHL. So who will be affected usually in this? Patients will be younger patient, and it is very important to notice that it is not associated with Epstein-Barr virus infection. Please remember this point. Epstein-Barr virus infection, Epstein-Barr virus infection is associated with classical Hodgkin's lymphoma, right? So please remember it is associated with classical Hodgkin's lymphoma, right? You remember classical Hodgkin's lymphoma? Those called as nodular sclerosis, right? Nodular sclerosis, mixed cellularity, right? ये जो हो गया mixed cellularity, nodular sclerosis, right? Lymphocyte rich हो गया, lymphocyte poor. So these are four types of classical. So they will be associated with Epstein-Barr virus, right? They will be associated with Epstein-Barr virus, right? And in these, we will see classical Reed-Sternberg cell and classical Reed-Sternberg cell. Please remember, again, this is again very important question. Classical Reed-Sternberg cells, which you will see in all of them, they will be positive for CD15 and CD30. So this will be positive in classical Reed-Sternberg cell, right? So that's the point you need to remember, which came in our exam also. 15 and 30 will be positive. Now understand, so Epstein-Barr virus will come in classical Hodgkin's lymphoma, and classical Reed-Sternberg cells will be positive for which marker? So they will be positive for CD15 and CD30. But when you are going to compare with nodular lymphocytic predominant Hodgkin's lymphoma here, this is non-classical, right? And that is why you can see in them CD15 will be negative, CD30 is negative. So both are negative. Here it was positive, here it was positive, but here you can see this is negative. 15 negative, 30 negative, right? So what will be positive? They will be positive for CD20, 45 and BCL6, and they will have best prognosis amongst all kind of Hodgkin's lymphoma, right? So that is the point you need to remember. So you got the point. So that is what I wanted to say about this nodular lymphocytic predominant Hodgkin's lymphoma. Please remember, Epstein-Barr virus infection is having no association with nodular lymphocytic predominant Hodgkin's lymphoma. It's a very important question in NEET PG as well as in INI-CT exam also, and this came in FMG exam also, right? So who is affected with Epstein-Barr virus? It is classical Reed-Sternberg cell, and they will be positive for 15 and 30. So let us see one by one. What are the options? BCL6 is negative. See, now by seeing this image, we can conclude that this is a popcorn Reed-Sternberg cell of nodular lymphocytic predominant Hodgkin's lymphoma, and they are BCL6 negative. True or false? First statement. Can you tell me in the comment box? BCL6 will be positive. So that is a false statement, right? So this is a false statement, right? So I'm just cutting it out. False statement. CD15 and 30 positive. CD15 and 30 is positive for classical Reed-Sternberg cell. That is also a false statement. They are 15 and 30 negative, and they'll be positive for BCL6, right? Not associated with Epstein-Barr virus. So this is our correct answer. This is our correct answer, and this will be our right choice. So Epstein-Barr virus is associated with classical, not with this one. Most commonly associated with HIV infection. Can you tell me who is most commonly associated with HIV infection? Which Hodgkin's lymphoma is most commonly associated with HIV? Can you tell me in the comment box? Which is most commonly associated with HIV infection? Lymphocyte predominant or lymphocyte poor or mixed cellularity? Which one? Very good. So Anurag has given me the first correct answer. Mixed cellularity. HIV infection is most commonly associated with mixed cellularity. So please keep that in your mind. These are the things which is the update which is wrongly given in Robbins. In Robbins, it is lymphocyte depletion. Please remember, these are the updates. We should remember that. Hodgkin's lymphoma, most commonly associated with HIV infection, is mixed cellularity. This point you have to keep in mind because this is a very important question. Not lymphocyte depleted. It is not lymphocyte depleted because in Robbins it is given, but it is not the correct answer. If you see the WHO manual or WHO classification where you will find this one, or even in Winthrop hematology, if you see, you will find that Hodgkin's lymphoma, which is most commonly associated with HIV, is mixed cellularity. So keep that in mind because in Robbins they have written in context with the Western countries because it is based on those Western countries. They are not entire world population, right? So please keep that in mind, right? So that is why I wanted to emphasize this point so that you should not commit mistake in your exam. Hodgkin's lymphoma most commonly associated with most commonly associated with HIV infection will be mixed cellularity. It is not lymphocyte poor, right? Most commonly, so this is also a false statement. So now you understood. Answer should be C, right? So this is the second question. Now coming to the last thing. Last question is here. A 42-year-old smoker male presented with the lung mass and mass was biopsied. Histopathology is given in this image. Which of the following is not true about this tumor? Not true about this tumor. During exam time, read the question very carefully. Not true, except, all these things you have to see very carefully and then you have to give your answer. See, the language of the question is very important. I repeatedly say that language of the question is very important. Probably if you catch the language, you can catch the answer also. Ishan Bansal has given me the first correct answer. Ishan Bansal has given me first correct answer. See, many of you have given this as a C. I will just tell you, what is your diagnosis here? What phenomena you are seeing in this blood vessel? Can you tell me? This is the bronchial blood vessel and this should be red in color, but this is not looking red, they are looking blue in color. What is this phenomena known as? Can you tell me what is this phenomena? And what is this cancer? Which lung cancer I am talking about? Which lung cancer image is given here? Can you tell me in the comment box which lung cancer is given in this question? What is this histopathology I am showing you here? What is this finding? Very good, very good. Anurag Tiwari is telling, Anurag, Manish Reddy, Ishan. Very good. So it is a Azopardi effect. Very nice. Azopardi effect. Where you will see in Azopardi effect. Very good, Antama. Azopardi effect is seen in a small cell cancer of the lung, right? Very nice. So please try to understand one thing. When examiner says smoking, right? When examiner says smoking, please remember this is the language which had been asked in NEET PG exam also. If examiner says smoking is most commonly associated with which lung cancer, and if examiner says smoking is most strongly associated with which cancer, most commonly and most strongly, these are the two different languages. Please try to understand, and this language you can see in the Robbins also. Most strongly associated cancer with the smoking is small cell cancer, right? And most commonly associated will be squamous cell carcinoma. Now you understand this line. So please remember, it is most commonly associated. If they are asking, that means squamous cell. Now this finding is the Azopardi effect. जो हम लोग यहाँ पे देख रहे हैं वो Azopardi effect है, right? And this Azopardi effect is seen in small cell cancer of lung. So if I talk about option number C, most strongly associated with smoking, so that should be a true statement. That should be a correct statement, right? And we have to find out which is not true. Which is not true. It is a true statement, right? Strongly associated is small cell cancer. Most common paraneoplastic syndrome associated with small cell cancer is Most common paraneoplastic syndrome is SIADH or Cushing disease. Yes, Abhilash, very good. Abhilash has told me dense core granule, which we are seeing, it will be seen on electron microscopy. That is what I wanted to say. Please remember, you have to catch the language. Sometimes, see, you all know it. I know that, right? No, 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 it's not hypercalcemia. That's what I'm saying. If there is a small cell cancer, na, in a small cell cancer, most common paraneoplastic syndrome is SIADH. It is more common than hypercalcemia. Squamous cell carcinoma, most common paraneoplastic syndrome is hypercalcemia. A small cell cancer of the lung, most common paraneoplastic syndrome is SIADH. So this is the point we have to keep in mind. So that is true statement. It will be positive for neurofilament. See, small cell, I have not written carcinoma, I have written cancer, because small cell cancer is a neuroendocrine tumor. They have a neural element, they have endocrinal nature. Neuroendocrine. Whenever you see any neuroendocrine tumor, they will be positive for the markers called as neurofilament. Right? They will be positive for neurofilament. And if you remember, in this INI-CT exam, there was a question, chromogranin positive. You remember chromogranin? So neurofilament, chromogranin, right? No, Lambert-Eaton is not most common. MD medicine, Lambert-Eaton is not most common. Lambert-Eaton is commonly seen in small cell cancer, but not most common. Did you notice my language? I said commonly seen in a small cell cancer of the lung, but they are not most common. Most common is SIADH. You will see myasthenia, you will see Lambert-Eaton, you can see hypercalcemia, but most common is SIADH. Right? So neurofilament and chromogranin. As I said, this was the this time INI-CT question also. So please remember, it will be positive for neurofilament and chromogranin. That is a true statement. Again, it is a true statement. So we will say that this is a true statement. So first, second, third is true statement. Dense core granule, D is not a true statement, because dense core granule you can see only on electron microscopy. Ishan Bansal, very good. Ishan Bansal is telling chromogranin A, CD56, 57. All these are marker of neuroendocrine tumor as well as small cell cancer of the lung. Right? So this point we have to remember, that dense core granule will be not seen on light microscopy. It's a false statement. It should be seen on electron microscopy. And remember, this electron microscopic view was the question in AIMS 2020. So now answer is D. Now I will discuss about this thing. What was the thing given here in this question? See, why I said it is a small cell cancer of lung. So why I said it is a small cell cancer of lung? Because if you look at this blood vessel, right, as I said, this is actually a blood vessel. This is actually a blood vessel, right? But what we are seeing in this blood vessel, there is a blue deposits. There is a blue deposit into the vessel wall, right? So what happens in small cell cancer of the lung, if you look at the small cell cancer of the lung, see, this is the nucleus of the small cell cancer cell. So this is the cancer cell of the small cell cancer. Their chromatin will be very delicate and they will leak outside. So chromatin is leaking outside, right? Chromatin, as we all know, that nucleus is blue in color because of the blue color chromatin. So this chromatin is going to deposit on the vessel wall, and when they will get deposit onto the vessel wall, what will happen? They will become blue in appearance. So this is called as basophilic staining of the blood vessel wall, right? So basophilic staining because of the blue color is known as Azzopardi effect. So what I am showing you here is a Azzopardi effect. So all these are Azzopardi effect which we are seeing into the blood vessel, where you can notice blue color chromatin is getting deposited throughout the vessel wall, and Azzopardi effect is seen in small cell cancer of lung because chromatin is leaking out. So what is Azzopardi effect? If examiner says it is a basophilic staining of blood vessel wall seen in small cell cancer, right? As I said, a small cell cancer of lung is an example of neuroendocrine tumor. So they are endocrinal in nature. So whenever you see any endocrine tumor, you will find two characteristics. Please remember, for any neuroendocrine tumor, when you will see their microscopic examination, you will find two characteristic finding. Number one, you will see fine stippling of the chromatin, right? So you can see there is a fine stippling of the chromatin. You can see fine blue dots are there. So this is called fine stippling of the chromatin. Fine stippling of the chromatin is famously called as salt-paper nuclear chromatin. So please remember, examiner, they use these wordings: salt, pepper, nuclear chromatin. Salt, pepper, nuclear chromatin means fine stippling of chromatin is there. Salt, pepper, chromatin means we are looking into a neuroendocrine tumor. Now you understand? It can be small cell cancer, it can be carcinoid, it can be neuroblastoma, medullary carcinoma of thyroid, pheochromocytoma. All the neuroendocrine tumor will be having this salt, pepper, chromatin. So whenever examiner writes salt, pepper, chromatin, right, whenever they are having salt, pepper, chromatin, that means it is a neuroendocrine tumor. This is the first characteristic feature. Second characteristic feature, in the cytoplasm they will have neurosecretory granule. You cannot see neurosecretory granule in the cytoplasm. See, for the sake of understanding, I have shown you here, but you cannot see neurosecretory granules on light microscopy. To visualize them, to visualize neurosecretory granule, you require electron microscope, right? So that's what you have to understand. And on electron microscopy, when you will see, they will be looking like a dense core granules, right? So now you understand, dense core granule is nothing but it's an electron microscopic view of the neurosecretory granule. Now you understand, my MD medicine, both are same. Neurosecretory granules, both are same. Yes, all these are endocrinal tumor, right? Adenoma is benign tumor. They are not having invasion, so we will not say that they are malignant, but we can call them endocrinal tumor. Okay, no, we can call them endocrinal tumor, right? So now dense core granule is again important feature. So if examiner says any neuroendocrine tumor, what are the two findings you will see is the fine stippling of the chromatin. Second is the neurosecretory granules, right? Neurosecretory granules, as I said, on electron microscopy, when you will see them, so they will be showing like this. There are dark, dense, round structure. So this dark, dense, round structure is called as dense core granules, right? And dense core granules, why they are dark and dense? Because they are having all the markers like a chromogranin, synaptophysin, neurofilament. So now you can see these are the questions which have been asked earlier in exam. Chromogranin, synaptophysin is a marker for small cell cancer of lung or any neuroendocrine tumor, right? Or neurofilament I had asked in this question. So neuroendocrine tumor, you will find this thing, right? So you got this point. So this is how you are going to see neurosecretory granule. And now I will show you, this is the electron microscopy. Now you can see the same electron microscopy. This came in INISET exam, right? In 2020, this question was asked. What is true about these things? So what is true about these things? Answer was neurosecretory granule. Simple. Electron microscopy of lung cancer is shown here. What is true about this? So it's a neurosecretory granule, right? So now you can see that neurosecretory granules are there and they will be having dense core granules. So all these things which you are looking here, all dark color structures are the neurosecretory granules. And what they will have markers of the neuroendocrine tumor: chromogranin, synaptophysin, leucin, neurofilament, bombesin, as I have told you, right? So this is how we are going to connect with these things, right? So whatever I have taught you, I am going to share this PDF in my Telegram channel. So this is my Telegram channel. You can connect it, you can scan it, and you can join me. And then I will be posting this PDF within 10 minutes, right? And you can go through with this. You just revise these topics, go through these topics in your last moment. This will definitely help you for your NEET PG exam as well as for FMG exam also. Yeah, I am planning to have them as a regular interval because my schedules are very busy. So I wanted purposefully to come for just for 15 minutes so that I can interact with you all, because I was not getting time for long hours. When I will get the long hours, I will go for the extended rapid revision session also for 2 to 3 hours. But I am just doing it so that we can be in connection. So subscribe my YouTube channel so that whenever I'm coming live, you should get, because I may not be coming all the time by 10 o'clock. Sometime I will be free at some other time. So I will be joining at that time also, right? And second thing, I will say that, see Instagram, my Instagram, I am posting one line revision. So that one line revision videos, some images I am posting, some exam strategies I am posting. So you follow that things, that will help you for your exam. I will explain tumorlet. Tumorlet is Again, one carcinoid type, neuroendocrine tumor, size will be less than 5 millimeter. So it will be called a smaller size carcinoid is tumor-led. I will take class on immunity. Don't worry. I will be having other things also. Right? So please go through this and please revise. And in the last moment, again, I will say that you please focus on the 5 years of the previous year question. Please revise 5 year previous year question paper. Which question paper? I will say you revise INICT plus NEET PG both, right? And those who are preparing for FMG exam, include FMG also along with this, right? This is must for your last moment. Along with this, what you should do, you should add up notes, your class notes, right? And try to write it down in your own language. See, because I am giving you PDF, you please don't try to dependent on that thing. Try to make tiny notes of important points only, right? So only important points, so that you can revise in the last moment, last one day or last 7 days or last 15 days. Thank you so much, Priya Gupta. Thank you so much. One line revision, I am posting. Yes, I am posting, Dr. Chetna, I am posting one line revision in my Instagram, so you can scan this my Instagram. You can see there is a story in my Instagram, and there are 51 line revision, so you just go through with that thing. Thank you so much, Dr. Abhijit. Thank you. PYQ you can get from any MCQ book. Dr. Ishan, you can get from the any MCQ. I will plan MD medicine for one electron microscopy session also. Don't worry, I will be keeping all that thing, and I will be keeping, Dr. Chetna. Don't worry, I will be keeping my motivation lecture also for you people on my YouTube channel, so that you should get motivated and you should get in a flow, in a momentum. I will tell you, you all are very well read, right? यू आर ऑल वेरी वेल. दिस टेलीग्राम चैनल का लिंक यहाँ पे है, प्रिया, डॉक्टर प्रिया. टेलीग्राम चैनल देखो, यहाँ पे मार्क कर रहा हूँ मैं. इसको आप स्कैन करोगे अगर मोबाइल से, तो आपको आ जाएगा. Thank you, Shalini. Thank you, Shalini. One line revision is very good. Whatever, see, all these things are interlinked to each other. So that's what I'm saying. You all know each and everything. Only thing is, last moment you have to compile them together, right? And that is why, to compile them together, you just need quick revision. You don't need exhaustive things. So don't fall trap into the question bank, all that thing. Just focus on 5 year question paper. Write grand test. That is one thing which I wanted to tell you. Write all the grand tests. Please remember, write all the grand test and try to revise your wrong answers. Revise your wrong answers. That is very, very important, because wrong answer means you are committing mistake, and if you are making it correct, then probably that can be your exam question also. So thank you so much to all of you, and good night. Again, we will meet tomorrow, same 10 o'clock. Bye bye.